Hello, everybody. I'm Dr. Rakesh Pandit, Senior Consultant and Head of Department at Akash Healthcare in Dwarka, Delhi. Today, I'll be talking about latest updates in hypertension. As we know, hypertension it's a leading cause of cardiovascular mortality all over the world. And one thing about hypertension is that it is a silent disease which is only diagnosed once you are screened for hypertension and you get yourself checked. There's no other way you can diagnose hypertension. And as per WHO, nearly 63% of total deaths in India due to these non-communicable diseases, and of which 27% are attributed to cardiovascular diseases, which affect about 45% people in this 40 to 69 age group. And raised BP is among the most important risk factors of cardiovascular mortality or deaths. And moreover, it remains poorly controlled due to low awareness about this disease and the less frequent checkups and lack of appropriate care through primary care and sadly very poor follow-up on the part of patients. And India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, which was about 29% and 28% previously. And this is the data given by WHO. And despite that, nearly half of the people of this 51% of the men and about 41% women with hypertension are unaware of this condition. And additionally, over 62% of the men and more than 53% of women living with hypertension don't get appropriate treatment. And surprisingly, medicines were used in fewer than 1 out of 5 men and 1 out of 4 women with hypertension. And this is the data released by WHO in Lancet 2021. And International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines, and the inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource of poor settings. And optimal care refers to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The American Heart Association and American College of Cardiology has released a scientific statement in 2021 offering new guidelines for managing stage 1 hypertension among patients with low ASCVD risk, that is among the low risk adults who don't have any atherosclerotic cardiovascular disease or a 10-year cardiovascular disease risk with less than 10% with stage 1 hypertension. Stage 1 means BP around 130 to 139 systolic and 80 to 89 diastolic. Management starts with non-pharmacological therapy, that is lifestyle management with diet, exercise, and cessation of smoking, alcohol. If blood pressure remains uncontrolled at 3 to 6 months, then we should be considering starting a pharmacological therapy in those cases. And as we have seen during last few months, that ARDS is potentially a fatal condition which involves lungs, and an expert committee associated with severe this COVID-19, and it was seen that these patients had mortality because of ARDS. And a recent study which appeared in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in COVID-induced ARDS. So metoprolol is an important part if we are treating COVID also. Then lower systolic blood pressure targets down to 110 to less than 130 range substantially reduce CV adverse events in the STEP randomized trial, affirming the sprint findings for an older Chinese population. And among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk findings. From now, a second major trial supporting a lower target could unite the guidelines, which even most US professional societies agree and the thresholds range of 130 to 150 millimeters of mercury. In a study by Zhang W. et al., which was published in NEJM 2021, this was the data from that only, and with regards to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend the diagnosis of hypertension that should not only dependent on the office BP measurements, that is the patients coming to a clinics, but it should be also on an out-of-office management measurements, which could be either an ambulatory blood pressure monitoring done at his own convenience, or a home blood pressure monitoring. 24-hour and nighttime BP measurements were associated with greater risk of mortality and the composite of CV outcome. Thus, they must be considered as the most relevant measurements for estimating cardiovascular risk. For every 20 millimeter systolic and 10 millimeter diastolic increment of BP measurements at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal BP, and the 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. And considering high non-adherence treatment, the importance of combination therapy is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of low BP targets, we should start an antihypertensive therapy with an initial dual fixed dose combination, which may be an ACE1 or ARB plus a calcium channel blocker or a diuretic. And recently, the HYGEA study represents the largest study that tested nighttime antihypertensive treatment. And in the trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CV reduction, and the largest study included a total of 19,084 patients, hypertensive patients, and during an average follow-up of 6.3 years, 1,752 participants experienced the primary CV outcome, and an ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The relative risk reduction for cardiovascular events was significantly improved for nighttime treatment when compared with the daytime awakening treatment. Thank you very much.